Hi, good afternoon. It's John Snyder. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn on a Thursday afternoon. We're really excited to have Irene Tien here, our acting chair of emergency department. I hope I got that right, Irene. Yes. She's going to give us a talk on under pressure, an unusual case of compartment syndrome. Next slide, please. So just a quick reminder, we have shifted our CME credits to Category 2, depending on whether you are which board that you certify with. Category 2 credits basically are self-reported credits for educational activity. So depending on how your board does it, you can report this as self-reported using that this is Category 2 AMA. So feel free to click on this link if you're having trouble figuring that out. You can also email myself if there's any concerns. Next slide. I'd like to tease the next couple of weeks, Lunch and Learn. We do have, it's already the 28th next week. Wow, we have Dr. Glicksman, one of our otolaryngologists, going to be talking about sinus disease, what you need to know. And the following week, we are really happy to have Shams Iqbal. He is, probably all know him because he's probably taking care of all your patients, but you may never have met him. He is our interventional radiologist at Newton-Wellesley Hospital, and we asked him to come and talk about some of the cool stuff he's been doing to your patients. So I'm really excited about that talk. Also, please remember that all these talks, we do archive them up on the web. They just go to YouTube and search Newton-Wellesley Medical Group Lunch and Learn. And we are carving out a place on our new intranet to have this all listed for one click. That's coming soon. Next slide. Just a quick reminder of our Thursday drop-in physician wellness initiative, which is a virtual meditation, which is run by a professional. We've gotten some good feedback from that, so feel free to drop in on that. That would be tonight at 5 o'clock. Next slide. And now I'm going to turn it over to Irene. Thanks so much for doing this, and I'll see you back at about 5 minutes to 1 or so.
Thanks so much, John. And thank you all for taking your lunchtime to join me in talking about compartment syndrome. So I want to start this case in the PCP office. This was a 51-year-old man who presented to his PCP with left lateral, anterolateral lower leg pain, stiffness, and numbness for 2 years. He's had ankle brachial indexes, sports medicine and neurology evaluations, and EMG, which showed mild bilateral sensory polyneuropathy, a tib-fib MRI without a clear cause around 3 years prior. And after a few days ago, he walked 1.5 miles and had worse pain and tightness in the same area with numbness and difficulty with dorsal and plantar flexion of his ankle due to pain. Also some intermittent muscle cramps, and took some over-the-counter oral and topical medications, but it's not been helpful. So in the office, his exam showed tight muscles in both calves without warmth or erythema, some pain with palpation and flexion of the ankle. He was asked to stop his rosuvastatin and sent to outpatient lab for some stat labs, which was notable for CPK elevated at 14,145, and was subsequently sent to the emergency department the following day. So we saw him in the emergency department, and he was evaluated by our team, and was noted to be a 51-year-old male with a history of rhabdo related to simvastatin therapy 7 years prior. Non-rosuvastatin for 2 years, now with 3 to 4 days of redness, swelling, and pain to the lateral lower left calf. Initially, he had pain in both calves, but the right leg is now pain-free. He has no other complaints. His past medical history is as you see it there. Some anemia with unknown etiology, bipolar disorder, hypertension-related renal disease, insulin-dependent diabetes, glaucoma, hyperlipidemia, history of elevated CPK on atorvastatin, hypertension, renal stones, low T, steatohepatitis, CAD, HIV, glaucoma, and renal stones. His med list, as you can see here, pretty consistent with what his problem list is. And on examination in the emergency department, he was known to be afebrile, a little bit hypertensive, bit tachycardic, not tachypnic, with a normal room air saturation of 96%. His peripheral pulses were normal. He had some erythema of the leg, some warmth, induration, and tenderness of the lateral left lower leg, but distal sensation to light touch appeared to be intact. He had a duplex ultrasound of the left leg in the ED that did not show a DVT. He had some lab work drawn, which showed a mildly elevated white count, baseline renal insufficiency, a mild bump in his transaminases, and a rising CPK from 14,000 the day prior to 17,000 the day of. He had some blood cultures and Lyme titer sent, and Ceph was given and was admitted with a diagnosis of cellulitis and rhabdo. While in the hospital, he developed worsening left anterolateral lower leg pain, numbness over the dorsum of the left foot and the first web space, and pain with passive plantar and dorsiflexion of the left ankle. His left lateral compartment of the lower leg felt tense, was tender to palpation and warm. He was seen by the vascular surgery service urgently and was taken to the OR for four-part compartment fasciotomy for compartment syndrome. And in the OR was noted to have muscles in all compartments that appeared viable. Ultimately, he was discharged on postoperative day 6 off of his rosuvastatin and his fenofibrate, and did actually quite well after a period of management of a non-healing wound, which is not unusual in these situations. So I thought this is a good opportunity to talk a little bit about compartment syndrome, something we often worry about. I think sometimes there's a bit of confusion about when we should be worried and what we should do in this situation where we're concerned about it. So compartment syndrome basically refers to elevation of a muscle compartment where the perfusion pressure of the muscles in the compartment is compromised by increasing pressure in that compartment. So if you look to the diagram on the right, oftentimes it starts with swelling of the muscle or other soft tissue in a compartment. And once the compartment pressure rises to about 10 to 15 millimeters of mercury, then you start to note some lymphatic and venous obstruction, which increases the pressure further. And then as the pressure increases further beyond a pressure of 25 millimeters of mercury, start to lose some tissue perfusion. Then you get tissue ischemia, which leads to increased endothelial permeability, interstitial edema, and you can see how this is a snowballing situation where ultimately you end up with muscle necrosis, neurologic deficits, and loss of extremity viability. So most commonly we think about compartment syndrome being caused by some sort of intra-compartmental increase in pressure. So often from compartmental volume increases, like from fractures, especially tibial fractures, pediatric supracondylar fractures or forearm fractures. We also think about in the setting of crush injuries or revascularization injuries. You can also get increased compartment pressures from extra-compartmental sources. For example, constrictive dressings, a cast that's too tight, circumferential burns are common examples of where extra-compartmental pressure causes increased intracompartmental pressure. And then you can have a less common source of a compartment syndrome is exertional or chronic compartment syndrome, where when you see individuals who are involved in major changes in activity level, so people who didn't really run a lot, now running a lot, or people who do have a lot of running or a lot of physical activity like long distance runners or military recruits, you can actually see people who develop compartment syndrome with exertion that resolves when they rest. And sometimes this can lead to acute compartment syndrome where the compartment pressures do not drop with rest. So we'll talk about that a bit more later. It's important to think about risk for compartment syndrome not based solely upon somebody's activity level. You also want to think about cumulative risk factors for acute compartment syndrome. So things that may cause myositis can increase your risk for compartment syndrome. So certain medications like statins and fenofibrate, steroids, antimalarials, and colchicine, viral infections like the flu, EBV, HIV, CMV, Coxsackie virus, parainfluenza, or adenovirus are certainly things that can cause myositis, which can accumulate, can be a risk factor that when combined with other risk factors may increase your chances of getting acute compartment syndrome. There are medications that can interfere with statin clearance, so some HIV protease inhibitor drugs, macrolide, cyclosporin, gemfibrozil, fluconazole, and then things that can cause rhabdo, like use of stimulants, agitation, or exercise. Patients with high muscle bulk, although some people dispute this particular risk factor, and certainly trauma. Since this patient had lower leg compartment syndrome, I thought we would use this as an example of some things that you might look for on exam when you have a person who you think might have compartment syndrome. So the lower leg compartments are broken down into 4 compartments: the anterior, lateral, deep posterior, and supraposterior compartments. It's helpful to kind of know what the muscles in the different compartments do and where the sensation, what nerves go through those compartments and what part of the body they provide sensation to, because some of the symptoms that you might find or signs that you might find on exam in a patient who you think has compartment syndrome relate to symptoms related to those particular pieces of anatomy. So for example, in the anterior lower leg compartment, you'll have muscles that allow for dorsiflexion and inversion of the ankle. And so if you have increased compartment pressure in that area and you're trying to look for findings on exam, you may do passive dorsiflexion or passive inversion of the ankle. And if that's quite painful, that might make you concerned about the anterior compartment of the lower leg. It also obviously has muscles that allow for extension of the toes and sensation in the web space between the first and second toe on the dorsum and then on the sole of the foot. Can be areas where you would test for decreased light touch sensation of the left versus right, for example, to look for evidence of that compartment issue. And then the lateral lower leg compartment, you'll see allows for plantar flexion and eversion of the ankle, and you'll look for sensation loss over the dorsum of the foot. In the posterior, deep posterior lower leg compartment, you're going to look for pain with passive plantar flexion and inversion of the foot, pain with passive flexion of the toes, loss of sensation over the heel or the sole of the foot. And if you're concerned about the superior posterior lower leg compartment, you may get pain with flexion of the knee, plantar flexion of the foot, or sensation again over the heel and sole of the foot. One of the ways that we would determine whether somebody has acute compartment syndrome is to measure the actual pressure in the compartment itself. So this to the left here, the photo is an example of a manometer, basically to look for the pressure within a particular compartment. And essentially it's just, you can see there's a number on the white box that gives you sort of the pressure in millimeters of mercury of that particular compartment you're measuring. One of the challenges with measuring compartment pressures is that the position of the extremity, the position of, let's say, in the lower leg, if you're measuring compartment pressure, the position of the foot are going to really affect how you measure that compartment pressure. So we in the emergency department do not ourselves do these compartment pressure measurements. We ask orthopedists to come to do that. Mostly because obviously you want to make sure it's done correctly, but also they're going to need to be the ones who make the decision about whether they need to take the person urgently to the OR or not. So it makes sense for them to look at that themselves. So how urgently does the pressure need to be released if a person has acute compartment syndrome? So up to a third of cases have necrosis of muscle within 3 hours. Neurologic injury can be reversible within 4 hours. And a delay of over 12 hours can result in irreversible neurologic injury. Once you see a patient that has motor deficits, that's rarely reversible. So obviously, if you think someone has acute compartment syndrome, it really is an emergency. So that person should be sent urgently to the emergency department, and we in the emergency department request urgent orthopedic bedside evaluation in situations like this. You can, if it's an extra compartmental source of pressure to the compartment, removing a constricting bandage or a cast promptly can reduce pressures by 65 to 85%. So if there's a concern that there's a cast that's too tight, cutting that cast off urgently is actually should be a priority. Avoidance of dependent positioning of the affected limb can reduce pressures as well for obvious reasons. Gravity is going to pull fluid down into, let's say, the lower leg. But you also don't want to elevate the leg too much because that can actually cause decrease in blood flow to the compartment as well. So we kind of keep the extremity more or less, at a neutral position, not too high, not too low. A lot of times I see, and I myself guilty of this, sometimes you want to feel the compartment and say, oh, the compartment feels soft, so that's great. Unfortunately, our ability to clinically assess for compartment syndrome is not as great as we would like. But some of the things that are important to know is that the severe pain is usually the earliest symptom. And we always hear about pain out of proportion to exam. And that is, in fact, the earliest symptom that you will see with somebody with compartment syndrome. Oftentimes, this pain is worse with passive stretching of the affected compartment, which is why it's important to know what muscles run through each compartment that you're trying to test. And that pain can improve as the muscle necroses. So if somebody's been having pain for several hours and it starts to get better, that's not necessarily a good sign. As I mentioned before, assessment of the compartment firmness is really unreliable. So for the leg, one study showed it's about 24% sensitive and 55% specific for acute compartment syndrome. What you really want to do is you want to do repeated exams. You may want to do repeated pressure measurements, and you want to look for a combination of findings that are consistent with acute compartment syndrome. And the more of the findings that you find, the more likely the patient has acute compartment syndrome. So some of the P's that we look for are pain with passive stretch, paresthesias, and paresis, and pulselessness is the fifth one that we always talk about. Obviously pain, again, we're talking about pain out of proportion to exams, usually quite severe pain. Looking for pain with passive stretch of the muscle and of the concerning compartment. Paresthesia, so loss of light touch sensation to concerning locations. Paresis is a very late finding, and pulselessness is very late finding. We obviously do not want to wait for either of those two findings to occur. So here's one pathway for deciding when a person with acute compartment syndrome might need a fasciotomy. Obviously, you know, if there's unequivocally positive clinical findings, the person's going to go get a fasciotomy. Like our case, you know, once the person had a very hard compartment, you know, loss of sensation to the foot, that person, and they also had very good story and risk factors with a rising CPK, and it's a pretty clear case of acute compartment syndrome at that point. So that person's going to go get a fasciotomy. But if you're not sure, or the person's not able to give you information, or your exam is really non-conclusive, in that situation, this is most situations, we're going to ask for a compartment pressure measurement. So for us in the emergency department, we're going to be asking for the orthopedist to come urgently to the bedside to do an assessment, which will most likely include a compartment pressure measurement. And this pathway says, you know, a compartment pressure measurement of over 30 millimeters of mercury is an indication for fasciotomy. But you have to put a little asterisk there, because obviously nothing is black and white in medicine. And while that's the number we kind of look for, it's not always 100% the only sort of decision point in making the decision to take someone to the OR. A compartment pressure of less than 30, you might consider just doing repeated measurements. You might want to do further, you know, repeated clinical evaluations. And then if the pressure goes up, or you have other concern that maybe this person still has acute compartment syndrome, despite the pressure being under 30, then that person might go to fasciotomy. It's helpful to know that the normal resting pressure of a compartment for adults is around 8 to 10 millimeters of mercury, and in children it's a bit higher at 10 to 15 millimeters of mercury. And as I mentioned, you know, absolute pressure is not necessarily an indicator for fasciotomy. You know, for example, if there's a delta P, which is the difference in diastolic pressure to the intracompartmental pressure, if it's less than 30, you might consider a fasciotomy in that situation. So a delta pressure is something that sometimes might be measured. Certain cutoffs of pressure might vary depending on the anatomy. So if it's a hand, you might go with a lower cutoff for the compartment pressure as a reason for fasciotomy. If a person's hypotensive, you might also consider a lower cutoff of compartment pressure for fasciotomy due to decrease in perfusion. So for chronic exertional compartment syndrome, I find this rather interesting. I've seen a couple of cases in my career. It's certainly not super common, but it basically refers to compartment syndrome that's brought on by physical activity. We know that when person exercises, that the volume of the muscle does increase due to increased use and increased vascular flow through the area. But sometimes that can actually cause the compartment pressure to tip over into a period of local tissue perfusion issues. And the person can have symptoms that result in them needing to stop their activity. We'll often see this more commonly in athletes, especially runners and competitive athletes, and also military personnel. I've mostly seen this in college-age students or high school students who run long distance. 95% of the time, a chronic exertional compartment syndrome will occur in the lower leg. And then sometimes people who are competitive rowers or motocross participants, they may have upper extremity chronic exertional compartment syndrome. Usually it's described as a gradually increasing pain in a specific muscle region during exertion. And sometimes people will describe this as an aching, cramping, squeezing, tightness, or pressure type pain. And it's usually fairly predictable for the patient. They kind of know how far they can go before they start to have symptoms. And then often if they rest after 10 to 15 minutes, it does get better. A minority of patients also will have bilateral involvement of the compartments on either side of their body. Some of the symptoms that patients may complain of in addition to the compartment, muscle pain, is they may complain of some paresthesias. They might have numbness. They might experience foot drop if it's in the right compartment. And it's more likely if chronic exertional compartment syndrome is more likely if the pain is only induced by athletic activity. If it's very consistently in a specific location of a compartment, if the pain gets bad enough to make the person stop, and after exercise, if there's tenderness, very, again, localized to a particular compartment, or there's some sort of weakness of muscles of a particular involved compartment, that's very concerning for chronic exertional compartment syndrome. Theoretically, the symptoms from chronic exertional compartment syndrome really should resolve after a period of rest. Occasionally, that may not happen, and they may actually develop acute compartment syndrome. And then sometimes you may actually see muscle hernias on examination. This is an example of the tibialis anterior muscle herniating through the fascia of the compartment on this patient. How would you diagnose chronic exertional compartment syndrome? It's helpful to perform compartment pressure testing before and after exercise with more severe people who have more severe symptoms or neurologic deficits. No non-invasive testing, unfortunately, has been found to be as accurate as actual compartment pressure testing, but the criteria for diagnosis can vary. It's not super straightforward. So I would probably refer to an orthopedist to further evaluate, or a sports medicine person further evaluate this for this particular diagnosis. Some of the things that might be mistaken for chronic exertional compartment syndrome would be shin splints, stress fractures, tendinopathies, DVT, popliteal artery entrapment, or neurogenic or vascular claudication. And then in terms of management, there are several non-surgical interventions like modification of running surfaces, using orthotics, reducing the running volume, or cross-training with a different form of exercise, physical therapy to help with strength or flexibility, icing after training, gait retraining. And then if non-surgical interventions fail, then you may want to go with some surgical intervention, which would be surgical release of the compartments. Unfortunately for women and military personnel, surgical release of compartments usually doesn't result in as good outcomes as for other people. And if it's an anterior or lateral leg compartment or forearm compartment, people do tend to respond better to surgical release of the compartment. Just a brief conversation about acute compartment syndrome in children. So we think of the P's, 6 P's here for adults and acute compartment syndrome, but we want to think about the 3 A's for acute compartment syndrome in children. So kids who are having increasing analgesic requirements for an extremity pain, having increasing anxiety or agitation, you may want to consider compartment syndrome in the correct situation. For example, if there was blunt trauma or some sort of sports or exercise related injury, a crush injury, significant infection of an extremity, some sort of vascular injury, or non-accidental trauma. Most kids who have compartment syndrome have an associated fracture. The lower leg is the most commonly involved extremity. And kids tend to do better with muscle salvage for longer periods of time after the presentation of acute compartment syndrome. So for even up to 48 to 72 hours after the onset of acute compartment syndrome, they can still have very good outcomes with a fasciotomy. And the vast majority of kids do have full functional recovery after a fasciotomy. They also tend to heal better after fasciotomy. For adults, it's not unusual to have non-healing wounds, but for kids, it's not super common. So some take-home messages about compartment syndrome. It's an orthopedic emergency. So if you think your patient has acute compartment syndrome, please send them to the emergency department and we will urgently consult orthopedics to come and weigh in on that case. Consider compartment syndrome in patients with extremity pain and risk factors for rhabdo, crush injury, fracture, paresthesias, pain with passive stretch. Consider chronic exertional compartment syndrome in patients with severe exertional muscle pain, which interrupts physical activity. And the diagnosis of compartment syndrome can be complex, so you definitely want to refer them in if you're concerned about that. Don't rely too much on the 5 Ps to rule out compartment syndrome, but certainly if somebody has several of the more of the Ps you have and the right situation, the more likely it is the person has acute compartment syndrome. And think about the 3 As when evaluating kids with concerns from compartment syndrome, including agitation, anxiety, and increasing analgesia requirements. Thank you. That's it. That's all I have for you today. Does anybody have any questions?
Thanks, Irene. That was really great. Excuse me. Great review. I don't see any questions in the chat box. I had a question about the kids. There were some family docs on here as well. So if a kid comes in with a fracture in the lower leg, is going to have an increasing analgesic, burden, and also be quite anxious. So how do you kind of weigh that risk? And do you do a lot of compartment pressures on these kids, or you just tend to brace them and just see how it goes?
Most kids don't come in with a lot of swelling in their compartments unless they have a really displaced fracture. And I find that most kids do really well with immobilization and ibuprofen. And I would say that, compartment syndrome usually develops over time in situations like that. So you may, at the beginning, that you would expect at the initial injury, the child would have a lot of pain. And then once you've splinted them, you've given them ibuprofen, they should be getting better. But if instead they're getting worse and worse, then you should be really concerned at that point about compartment syndrome. So it's going to be, I think for kids, it's rare that we actually see a child who needs to come in and get a compartment pressure checked. I would say more based upon the pattern of the pain and the escalation of the pain would sort of make me concerned if it was more delayed. But the vast majority do great with ibuprofen and splinting.
And then the folks like the case you presented, when they go to the OR and they get the fasciotomy, I mean, are they essentially cured? I mean, do you tell your runners that they can continue to run, or what would be your advice going forward once the fasciotomy is done? Or does that close up?
I mean, I think that it for the majority of those patients, they do well, but it's not all of them. And I think part of it is that there's not 100% understanding of exactly why it happens exactly. So I don't know that I would be the right person to say what percentage of people get better, except to say that I have had patients who have come in after having compartment release due to chronic exertional compartment syndrome, and they do seem to do well, especially the college age and adolescents who've had to have that done.
Terrific. Well, thanks so much. And I hope everyone got to kind of put a face on a name for Irene. I'm sure she's seen a lot of your patients in the emergency department. Wishing everyone restful and a great weekend, and enjoying some championship football. And we'll see everyone back next Thursday for Dr. Glickman's talk. Thanks, everyone. Have a great day and a nice weekend. Thanks, Irene. Really appreciate it.
No worries.
Bye.